Good afternoon again, everyone. It is now 3 o'clock Eastern, and we are back for our last session today of day one of the Policy Practice and Innovation Conference. It is my pleasure to introduce Mimi Gardner, Chief Behavioral Health Officer at HealthLink, who will be presenting mobile integrated response teams for community opioid intervention today. Mimi Gardner is a graduate of the University of Chicago with a Bachelor of Arts and a Master of Arts. Ms. Gardner is responsible for guiding the behavioral healthcare initiatives of HealthLink, a federally qualified health center, and its providers. Her significant knowledge and experience in the behavioral health field provides her with the ability to be creative and innovative with underserved populations. Previously, she served as the Vice President of Accountability and Provider Relations at Behavioral Health Systems of Baltimore, where she focused on addressing access to care and best practices in treatment and recovery. Additionally, she served as the Chief Clinical Officer for Green Door Behavioral Health and as President and CEO of Capital Community Services in Washington, D.C., an outpatient community mental health center where she was responsible for the oversight, supervision, and quality assurance of all clinical services. It is my pleasure to introduce Mimi Gardner to present on mobile integrated response teams for community opioid intervention today, as she is spearheading the response within Stark, LaPorte, and Porter counties in Northwest region of Indiana. Mimi, thank you for joining us today.
Thank you, Sunny. Before I start, I just wanted to add talking about my experience in SUD, which started in the 80s. I have lived through, I want to say, 2 waves of the opioid epidemic, 2 waves that have been different. But I want to talk about how my experience was affected by the ladies who used to come into my office. And these ladies were all sex workers in a methadone program in New York City. And the experiences, the conversations that we had were not just focused on their uses of heroin, cocaine, and crack, but also on what brought them to the clinic. And a lot of it was about poverty. A lot of it was about trauma, unstable housing, poor parenting they received, and how they got linked with pimps, Johns. They talked about how they were on their own at 10 or 14 years of age. And they talked about situations of not having food. So this really shaped my understanding because it made it personal. And I think when you work with patients in the opioid crisis, you have to take it personal. You have to be available, and your goal should be to look at the strengths of the individuals that we work with, not just what's wrong with them, because that's not right. It's the strengths, because this is a group of people who should be empowered, who should feel good about themselves, and are able to make a lot of strides and effects in the community. The other piece I wanted to mention is that I've had a lot of training in the area of diversity and inclusion. And so as I was putting this presentation together, I was thinking about what was the best way to present this. So we will talk about health equity, we will talk about health inequities, health disparities, systemic racism, because those are things I think we need to tie in all together as we talk about the opioid crisis. And lastly, I just wanted to make sure that everybody is familiar with class standards, beautiful blueprint for how to provide work with clients from diverse backgrounds, the culturally linguistic appropriate services in health and healthcare, because there's pieces that are how you work with clients, what you need to look at, how you need to connect clients with resources, what should be your own self-awareness. So anyway, with that, I get started. HealthLink is a federally qualified health center which has 14 locations throughout Indiana. We are located in Lake County, LaPorte County, Stark County, St. Joseph County, and Porter County. And we have been around for 17 years. So today's agenda will focus on discussion of the opioid crisis. We will talk about social determinants of health. We will address health equity. Then we will address HealthLink's approach to care. We will describe what we're doing with the mobile integrated response team. We will talk about the model that we are using, which is called the trauma-informed recovery-oriented system of care. And we will talk about what you as an individual can do to combat this crisis. So we start with the opioid crisis is unprecedented and innovative programming is needed to address this public health crisis. Numerous strategies are needed to instill feelings of self-worth and foster empowerment. Involving people in recovery is key to addressing this crisis. We must understand the social, economic, environmental, political, and cultural forces that impact substance users. So one of the things that I think is very important to discuss is what is an opioid. Opioids are a class of drugs that can be synthetic or used for pain medication. So the synthetic ones you start talking about are illegal drug heroin. You talk about pain relievers like Oxycontin, hydrocodone, Vicodin, codeine, morphine, and many others. When we talk about pain medications, a lot of times people get addicted to heroin because they were prescribed medication, and with that medication, they started using it incorrectly and eventually became addicted to that medication, and then are finding that they no longer can get access to that medication, and they end up resorting to street drugs just so that they can feel that same feeling that it causes. There's also the synthetic compounds when we talk about fentanyl or carfentanil. And these are what has been affecting a lot of the people who started just using heroin on the streets. It's used in marijuana, it's been used in cocaine, cigarettes, and this is causing a lot of deaths. And when you've seen on TV, people in cars passing out, this has affected how people who have been using for a while, they're now dying from having drugs with fentanyl in them. And as we talk about opioid epidemic as a public health crisis. Mortality has increased and it has affected the overall life expectancy of men and women in the last 3 years. During the last 18 years, the opioid-related deaths account for 2/3 of all drug overdose deaths. The impact of the opioid epidemic cuts across age, gender, race, ethnicity, social economic status, geographical, rural, urban groups. Earlier on, when the epidemic was starting, it was not everywhere in the country. But in the last few years, it's everywhere. And there's been many different approaches to address the epidemic. Some have been through law enforcement. Some have been through what drugs are brought into the country. A lot of it has been through mass incarceration. And a lot of it has been through healthcare and finding diverse ways on how to deal with it. But this epidemic affects everybody. And if you have not been affected by use yourself, you know of somebody, you've worked with somebody, you've lived near somebody who has been affected. The key to battling opioid addiction is to prioritize our strategies and address the effects of social determinants. The 5 key domains of social determinants of health are the following. Let me define it first. Our health is determined by the social, economic, biological, environment risks or opportunities we experience. Social determinants of health are conditions in which people are born, live, learn, work, play, worship, and age. So it includes your social and economic status, your education, the neighborhood you live in, the physical environment, your employment, your social support networks, as well as your access to health care. Let's first talk. These social determinants are defined through the Healthy People 2020. And so we were going to use their guidelines, and we'll start with economic stability, poverty, employment, food insecurity, housing instability. These are 4 factors that will affect people as they live. So when you're dealing with someone who comes from poverty, and that has to deal with their lack of employment or their inability to find food, have food markets near them, or they're in unstable housing, which was poorly built, or situations in which they don't know if they will be able to continue to live. They might have slumlord landlords or whatnot. This is a big factor in working with the clients that we have. We look at education, the ability to graduate high school, the enrollment in higher education, language, the ability to understand literacy, ability to read and write, early childhood education and development. For many, they have had situations where it has been historical poverty. They have dealt with situations in which they were not exposed early on. Head Start is a wonderful program, and it creates opportunities for people to receive education, work with people who work on child development, and work with their parents. And many times people who in poverty situations may not have access to those resources. Health and healthcare. Let's look at your diet and nutrition, your smoking, your drug abuse and drinking, exercise and sleep, safe sex practices. There's instances where your diet and nutrition are poor because you do not have the funds to buy the appropriate food. You might be eating a lot of snacks, whatnot. Smoking, drug abuse, and drinking. You might have been raised where you were exposed early on to drug abuse and alcohol in your home, your entire family, or your community. Exercise and sleep. This can affect people in terms of not getting appropriate exercise, not focusing on exercise, and not focusing on sleep. Safe sex practices. We have people who are practicing at-risk behaviors, which will affect their overall health. And then healthcare, access to healthcare. Do you have primary care clinics in your neighborhood? Or do you go to an ER for your care? We do have a lot of people who use the emergency resources as their primary care doctor. Access to primary care. Do you have FQHCs in your neighborhood? Do you have insurance, or is the healthcare affordable? Neighborhood and built environment. Again, let's look at your access to foods that support healthy eating patterns, the quality of your housing. Some people are living in housing that the quality is poor. You look at the situations like in Flint where there's no water. You look at situations where there's lead paint still on the walls, or look at your communities where crime and violence are a big part of your everyday life, which affects you and causes trauma. I've had many of a client who's told me that every night they can hear the gunshots. There's a lot of gangs. There's a lot of violence, and that they learn how to live that way. Again, your environmental conditions, not always the best. And then we talk about your social community context, civic participation, discrimination, incarceration. You have friends, colleagues who also may be using or drinking, or who have a lot of issues with who've had numerous incarcerations. Faith-based communities. A lot of times minorities get a lot of strength and support through faith-based communities, but there may not be any in the community that you live. We go back to the family dynamics, your parenting structure, how you were raised. Was your family with a two-parent home? Was your one parent working all the time? Were you raised by your grandparents? And then we're going to talk about immigration. We look at what's going on today. We have families torn apart, families who are not together, children who are separated from their parents, people afraid to take jobs if they don't have the right identification, with the fear that ICE will come and take them and separate them from their families. And a lot of families came here due to poverty in the countries that they originated from, but here they are coming here, and there's just so much being, people's families are being torn apart unbelievably. We look at the race you came from, and we look at your gender. And I must say that one of my biggest things is do not blame the victim. With all these different domains I discussed, we really need to understand the opioid crisis, because we really need to look at how this does affect how people live, how they respond. And a lot of this is back behind power dynamics with institutional individual settings. And once we are able to truly address these power dynamics, we'll be able to advance equity and social justice for marginalized communities that have experienced and continue to experience structural inequalities. There are negative and positive impacts of social determinants, and they do accumulate over a person's lifetime, over a person's life course, and are passed down to future generations. Social determinants can cause health inequities and health disparities. And what does that mean? So when we're looking at all of these effects, they impact people receiving health care, how they access it, how they're able to pay for it, and it also helps create health disparities. Health inequity refers to the uneven distribution of social and economic resources, and these inherently impact our health. Inequities stem from systemic racism, historical disenfranchisement, and discrimination towards marginalized groups. So we look at how does this affect the minorities, low-income populations, members of the LGBTQ community, and substance abusers. These groups have been historically withheld from obtaining resources that are needed and are disproportionately exposed to a combination of health risks as poverty, violence, poor neighborhood conditions, and environmental health hazards. The main source of health inequity is systematic racism. As you look at the people out in the communities who are protesting, the biggest piece is about systemic racism. And these are issues that are on a system-wide level. They benefit minority populations. They create chronic adverse outcomes for people of color. When I'll start with the Jim Crow laws, housing laws, these were laws that were created for people that affected minorities who were trying, people of color basically, who were trying to buy houses. These are laws that so much affect people when they go to stores, when they are out there trying to get different types of items that the larger majority communities have access to. We look at things like mass incarceration. We look at people who are in jail, and we look at as minorities are the biggest percentage. And they don't have the same resources, the educational resources we look at. That we look at schools in urban areas and how schools don't have books. When I lived in Baltimore, there were schools that didn't even have furnaces that were working. So kids did not go to school. And these are things that will affect people and will drive people to be unemployed, to have more poverty in the community, more violence, intimate partner violence, lower graduation rates, and communities that have more substance misuse. When we look at health equity, what does that mean? Everybody has the same opportunities to obtain their highest level of health. The factors that influence health, employment, housing, education, healthcare, public safety, and food are addressed. People have access to more employment. There's more workforce development. Housing. People are given opportunities to purchase housing in neighborhoods that they never could get in before. People are allowed the ability to obtain loans to get in housing communities that neighborhoods that they normally could not attend. Education, that the education is addressing those who have difficulty with learning, and that the education has goals for people to graduate. There's tracks for people to get linked with training, trade schools, tracks for people to get linked with colleges and universities, healthcare, that there is a clinic in people's neighborhood, not the emergency room, which is 20 blocks down the street, but there's clinics actually there. People have access to the communities. Public safety. People feel safe in their communities. They do not feel that when they call 911, no one will come, that they feel that they can go out and play, that the gangs are not permeating the streets and everything. There's grocery stores, when we talk about food access, that there's grocery stores that they can get fresh vegetables, fresh fruit, that the access is there, that the jobs are in their community. Anti-racist efforts are implemented to ensure the delivery of quality care. That we are making sure that the doors are open to everybody, that we are not racist in our delivery of services, that our services look like the people who come in that we serve, that we have services available, that someone is uninsured, that we will be linking them up with insurances. Barriers such as poverty, discrimination, and consequences and lack of quality education are removed. This is how things should be. And this is what we strive for in the communities that we work with. Health disparities. Health disparities are health differences between different groups. And these health differences can affect how people contract illnesses, how severe the illnesses are, how many people have combated the disease, whether healthcare is accessible, how many people get screened for a disease. So you look at COVID-19. COVID-19 has affected minorities, communities at a disproportionate rate. And so when we look at that, we look at screening and testing. Was it done? As you see, there's a lot of innovative programs which are hitting the streets in a lot of the urban cities and some cities in the South where many minorities were affected. So the testing is right there on the ground. HealthLink is out there in some of the communities doing the testing. They're coming to the community. The community doesn't just have to come to them. With the diseases, we're looking at infant and maternal mortality, high rates of diabetes, high rates of hypertension, high rates of substance abuse. And a lot of this is dealt with by looking at where groups of people are and where the services are. So how do we, to combat health disparities, address what these issues are and create innovative programs to address these issues? And screening. And that's a big piece, that when someone does show up for healthcare, we need to be screening them for mental health. We need to be screening them for substance usage. We need to be screening depression, anxiety, because these are the ways that we can address these issues and this is our prevention. And this is how, when we have access to these communities, let's screen so that if I intervene now, in the future, you will be doing much better versus going into a full out exposure to the different diseases. So let's talk about substance abuse now. Social determinants of health create barriers to prevention, care, and treatment. Economic hardship, social isolation are main reasons for drug abuse. Poverty, in conjunction with untreated mental health, lack of stable housing, are correlated to working with underserved communities. Viable employment, safe housing, community reinvestment initiatives are needed to reduce high overdose deaths. When our clients come to us, these are the major issues they talk about, and these are the major issues that we see. So this is one of the reasons why when people come into treatment, these are the things that they need help with. How do we provide that help? Obstacles, lack of access to evidence-based care and treatment. A lot of it is due to, I don't have transportation to get there. Limited treatment options, and a lack of SUD and OUD prescribers. There's a lot of fear and mistrust of the medical system due to previous experiences of prejudice or stigma. For people living in poverty, their priorities may be on survival. I don't have a place to live tonight. I don't have any food in my refrigerator, and I have 4 kids I need to feed. It's not safety. There's no safety. When I go out, I can only go out at 7 o'clock because all the gangbangers are out at 1 o'clock in the morning. So the kids can't play outside. So these are reasons people do not seek care. These are reasons people are like coming in, and when these are issues, they're not thinking about, oh yes, I didn't take my pills today. Those who are underinsured or underinsured may not be able to cover ongoing treatment. These are some of the reasons people don't come back, because they don't have the money to pay for services. So either linking them up with a health navigator is one solution, or allowing them to have and having available a sliding scale fee so that they can pay what they can afford due to their incomes. HealthLink's approaches to care. As an FQHC, we focused on patient-centered care. Patient-centered care is where the patient participates in their own treatment plan development. They are cooperating, working as a team with health professionals. They are listened to, they are informed, and they are involved in their care. Care is respectful, responsive, individual preferences are heard, needs and values are listened to, and ensures that the patient is involved in all clinical decisions. This empowers the patient. This gives them an opportunity to feel good about themselves, and this allows them to have control as they participate in care. Integrated care model. HealthLink prides itself in being able to provide an integrated care model, which means when you come to HealthLink, you will not only get your primary care needs taken care of, but also if you have mental health needs, you will be able to receive services. If you have substance abuse needs, you can also receive services. We pride ourselves being a one-stop shopping. We also are able to provide dental services. We have services for optometry. We also have services for chiropractic. This creates a team-based approach where your mental health people, your addiction people are talking to the provider. And all of this is in the same setting. So when a treatment plan is developed for a patient, all of these facets are included. The benefits of integrated care, it promotes coordinated care. We walk down the hall and talk to a provider. All of that is under one roof. So this way that when someone receives care, it is all together and everybody's talking to everybody. We're dealing with somebody who comes in who's depressed. We're dealing with somebody who comes in and has just lost a loved one, at the same time having hypertension. And this increases access to services, it improves the overall quality of care, and it lowers your overall health care costs because it's all within the same visit. Now we will talk about our HealthLink Mobile Integrated Response Team. All together in the same building, regardless of a patient's ability to pay. We serve our population. We offer a sliding scales fee. We provide comprehensive services. We provide transportation when needed, and we link people with community resources, hospitals, and specialty care. One of the unique features is FQHCs have developed strategies for years on how to address social determinants of health. We start by screening our patients to identify their social needs. We collect and analyze that data so that it helps us develop future interventions. We strengthen partnerships with other community organizations that serve the same population. We are constantly working with our community providers for resources, linkage, and then at the same token, they can refer to us, and then we're all working together for one patient. We integrate home services with primary care needs of our patients. So we're not just looking at what happens with the patient in our clinic, but our program is able to look at what happens to the patient in the home. And we have now been able to expand our services to include medication-assisted treatment. We provide Suboxone and Vivitrol for our patients. And then we're able to expand our behavioral services within the clinics. Our role in the opioid crisis. We are able to improve the opioid prescribing. We're able to expand the use of naloxone. We promote the use of the state prescription drug monitoring program so that when a patient comes in, we're looking at the past medications that they've received so that someone isn't getting say they're hopping from doctor to doctor, we're able to see that. And we're able to advise the client when they come in the door of what they can and cannot do. We implement some of the state strategies that prevent high-risk prescribing and opioid overdoses. We stop stigma and discrimination. And again, we expand the usage of MAT, which is an evidence-based treatment. So let's talk now about what the Mobile Integrated Response Team is able to do. First of all, HealthLink received funding from the Department of Mental Health and Addictions in June 2019 for $1.5 million to address the opioid crisis. The grant focuses on 3 communities which have a high percentage of overdoses and limited service and limited providers. And those 3 counties are LaPorte, Porter County, and Stark. And with this, we've been able to create 3 trauma-informed recovery systems of care and 3 mobile integrated response teams. The goals of the grant were to develop the 3 teams, to hire and train peer recovery coaches, to work in the community, to work with an ER so that we can get them to be able to provide MAT in the ER, and then we're able to link the client in the community. And this is a big deal because it has been found that when a client comes to the emergency room in crisis, that if they are immediately medicated with MAT and immediately connected to an organization in the community, they are more apt to stay engaged in treatment. And so we have been able to accommodate that, but I will talk later. Also, that we are able to work collaboratively with the local community mental health centers and other FQHCs in the community. That we provide wraparound services to individuals, that we increase the amount of data waiver providers, and these are providers who are able to provide medication assisted treatment, and we increase the number of certified peer recovery coaches in the community, and that we're engaging SUD, OUD users earlier on in recovery. And lastly, to improve the health status of those through primary care interventions. So these are the goals that we stated we would be able to meet. We also are working with pregnant OUD users and getting them involved in treatment earlier on, and then working with their OB providers so that we can monitor their progress and that help with them delivering a healthy baby. So our teams, our 3 teams are composed of an EMT or paramedic, law enforcement officer, and a peer recovery coach. Each team is trained how to respond to an opioid emergency. They will counsel and any overdose victim during the 72 hours of their recovery window. But we are also working with patients who have a current history of using substances and have had previous history of OUD. What we found is that the amount of clients that have come to us with overdoses that have just occurred have had numerous overdoses and may not have had someone there to assist them. So we expanded our entry into their program of people who've had past overdoses. And we are currently, like I said, in the 3 counties working with individuals. We have a total of about, I want to say, over 12 officers that are routinely involved. We have about 7 EMS paramedics who are actively involved in all 3 counties, and we have a total of 9 peer recovery coaches who are working with the population. The wraparound services that we provide. First of all services are provided by peer recovery coaches. Peer recovery coaches bring with them lived experience of recovery. We are fortunate that we have 9 individuals who have been through treatment or not, but who are dedicated to working with people to help them get through, to start recovery and help them maintain recovery. We are in the jails, we are in the emergency rooms, we're in the communities, we're in our clinics. And we are screening and assessing and providing resources. One of the beautiful things about our program is we are addressing social determinants. We are addressing housing needs. We assist people with housing placement. If people don't have food, we have what are called flexible funds for social determinants or health. We will assist people with getting food. We'll assist people with getting clothing. We've had many people who have been discharged from jail. They only have the clothing on their back. So we have assisted them to help them re-enter the community. We've had situations where we've had clients presented with domestic violence, and we have linked them with different domestic violence resources in the community. We have stayed with them through the evening. We've gotten calls. We're 24/7. We are available, and we're constantly working to make people's lives better. We provide transportation who need access to services and to entitlements. So we're getting people to the Department of Family Resources to sign them up. We're getting people to Social Security offices. We're getting people to sign up for insurance. We get people who have lost their licenses. We're working with them to get their licenses back. We're working with child support to help some of our clients who might have lost income because they haven't paid their child support. We're helping people deal with issues that have affected their life, which impacts their substance usage. We have linked many of our patients with withdrawal management sites, with IOPs, outpatient services, support groups, AA, NA, Smart Recovery, Celebrate Recovery. Some of our peer recovery coaches have been providing those services themselves. We're linking patients with medicated assisted treatment. We provide transportation for those services. We speak to those programs so that we know how those clients are doing. We work with probation, community corrections, so that we are letting them know that this person is attached to treatment and how they are doing in care. We are addressing people's trauma and their mental health their needs. And if we do, and I want to say about a third of our patients do have mental health needs, have had prior services, or have presented suicidal. And we have linked them with the appropriate community health services. We have provided our services face-to-face, in the home, in the communities. We've provided services in our clinics. And with COVID-19, we have now begun telehealth services. Back in March, everybody was able to receive Zoom accounts. And so our workers were able to provide the face-to-face, but as well as the Zoom internet services. And again, we are providing a lot of crisis management, a lot of supports for our patients. Our accomplishments. As of June 2020, we've established 3 teams. We've trained 3 communities, LaPorte, Porter, and Stark, on the TROS model. We've worked with LaPorte Hospital to where they are able to provide the MAT in the ER and then link with one of our clinics. We have trained, all of our peer coaches are trained on administering naloxone, and they are able to go into the homes and train the individuals. So every client that's in our program has also been trained by our staff and then left with some naloxone. We've collaborated with LaPorte and Stark County jails for inmates. We start working with the clients while they are in the jail so that when they're discharged, we're right there to take them out and get them reintegrated in the community. And we've been able to increase the number of providers that for MAT. We now have 16. We have provide MAT services in our Knox clinic, our Michigan City clinic, our LaPorte clinic, our Valpo clinic, our South Bend clinic, our Mishawaka clinic, and we're targeted to have East Chicago up and running, but with COVID-19, we had to push that back. So our goal is to get that back on track in September. We have 3 newly certified ICATA trained recovery coaches, and we were scheduled in March to train 29, a total of 29 people as certified peer recovery coaches. That has now been rescheduled, and that will be occurring in August. We have linked SUD, OUD providers early on in primary care. We have been able to have people who had not had primary care in years, so we've been able to address issues of anxiety, hypertension, Hep C, HIV, And we do, because we are a federally qualified health center, have access to what's called 340B prescription plan. So some of these medications are able to be given to patients on a super discounted level. Hence, people come back for care. Our peer recovery coaches, as I said, we're providing NA Smart Recovery support groups in all 3 counties. And we've just begun a partnership with a pregnancy outreach center where we are on site and we're working with them, educating some of the women and couples about pregnancy and addiction. Trauma-informed recovery-oriented system of care. This is the model that has been chosen by the Indiana DMHA. And what it does is it integrates trauma-informed approaches with a recovery-oriented system of care. And working together, we are able to identify what our community needs are and develop a readiness change assessment, develop a team of stakeholders in each of the 3 communities who are willing to combat the opioid crisis. We all sat down on 2 occasions where we decided on the steps looked at the need for recovery housing. The action steps looked at the need for patients to have access to care. We looked at the location of services and how we can get people to the variety of different services, including ER care. We've looked at where services are located so that we are having educational sessions with shelters. We're having educational centers with food banks, letting people know where services are available because this is where this population does attend. And that is currently in progress. Community engagement. The community can have a powerful role in addressing the opioid crisis by providing education, naloxone distribution, educating community members on safe use, storage, and disposal of prescription medication, supporting education for health, supporting individuals as they start and maintain a lifestyle of recovery, increasing public safety, reducing recidivism, preventing drug overdoses, and embracing medication-assisted treatment. Community approaches we recommend is that you address social determinants in your practice. You engage churches in the faith-based community in combating the opioid crisis. They can reach a lot of people on one given day. Become trained in how to use naloxone, connect with organizations in your community, and number 5, become more aware of substance abuse issues and more aware of treatments that are available and connect in your organization with those resources. And as an individual, what can you do? We ask that you listen and engage. You address systemic racism. You understand the effects of social determinants of health. You become a change agent. You understand the power dynamic that exists and you try to combat it. You learn the history of racism in your community. I also add to that, you need to learn the history of the opioid crisis. And when you start, you look back to the 1700s when opium came into the country. It is necessary for you to truly understand today when you understand what happened yesterday. And it's a very interesting way to look at it, and it also shows you on how the crisis has gotten to where it is today. And lastly, you combat stigma and discrimination. I have 10 minutes for questions. I know it was a lot of information in a short amount of time.
Mimi, thank you for that comprehensive content and showcasing all of the different models of care and how HealthLink has been applying those models directly into the community, both your improvements and also your customizations as you've approached local community feedback and the collaborations and excellent relationships that you've built within Northwest Indiana region. We have had a tremendous number of comments thanking you for the excellent content and for the detailed information. We did have a logistic question asking of which counties does HealthLink serve today?
It's Lake County, Porter County, LaPorte County, Stark County, and St. Joseph's County.
Fantastic. We've had some questions regarding, of course, your services. Is there a way for other counties to essentially participate and glean your services that you're providing today? Essentially, are you training other counties to do what you're doing today?
In terms of mobile integrated response team?
Yes.
Right now, our focus is on those 3 counties, but we are open to working with other communities. One of the things about this is that we have partnered with other counties in the state, and we have learned from them. So I'm more than willing to be contacted to let you know what we're doing, how we're doing it, because we all learn from each other. And they do things that we may not do that we have incorporated now into our practice. And this is something that I think does need to be more replicated. This actually came out of a program in Ohio, and it was originally called the Quick Response Teams. And then it came to Indiana, and the original funding prior to ours was for Quick Response Teams. And we built upon what they did. And then we heard them talk about what was positive and what was needed. And then we made sure we incorporated that into our services. So yes, definitely. I'd be more than happy to do that, and more than happy to, have you come to us, spend a day with us, and just talk about what we're doing.
That's fantastic, Mimi. Mimi, are you comfortable in sharing some outcomes measurements of your programming to date?
We have had 217 clients that have actually been referred to us. We've been, I think today makes 8 months. So we've been around 8 months. Of the 217, we have serviced about 80 clients. We have discharged a few. So we're at a rate of, we get referrals from police, neighbors, different probation, DCS, and of those clients, we've been able to open 80 cases. So we're at a percentage of about 40 that actually get to us, and then actually when we call them initially, our policy is 72 hours to make outreach, and of those 72 hours, then we talk to them about what the program's about, what it does. And so 80 people have actually signed up. We stay with clients until they no longer need us. We always said that we would not limit the amount of time that people can be involved in the program. We have had a total, I think it's about 80 different resources we've gotten them from. It continues to spread in terms of word of mouth of how we work with different organizations. I'm always open for a conversation with an organization to find out what they do and how we can partner. Trying to think what else. We've discharged maybe
Fantastic.
20 clients, yes. And most of our clients who come to us have opioid disorder, but then we have alcohol use disorder. We have clients who come to us with methamphetamine usage and cocaine usage, and some with the synthetic marijuana. So as long as opiate is involved, we're able to work with you. Okay.
It's fantastic outcomes, Mimi. Thank you so much for sharing, and significant progress within that short time frame of starting the program just 8 months ago. We have additional questions here on regarding the program expansion. Do you have any plans to expand and any plans to come into Indianapolis?
Oh, no, we try to stay where our clinics are, but we are open to expanding in the areas where our other clinics are, which would be in Lake or St. Joseph County. But I do know that there is services in Oak Lawn County, but we would love to expand our services. So
wonderful. Mimi, you've certainly had a tremendous career in SUD and OUD, substance use disorder and opiate use disorder. Would you share some of your additional vision of where else you would like to take this programming?
One of our focuses we'd like to work is neonatal abstinence syndrome, working with pregnant or parenting moms, working with postpartum moms. Our goal is to expand the services more so. We're doing it now, but we want to do more. We're working with paramedicine. There's a program that we're collaborating with that we're going to be able to work through somebody's pregnancy, and there'll be an EMS worker, as well as a peer recovery coach, as well as a social worker within the home. And remember, we're already doing home-based services now, but in the home throughout the whole entire pregnancy and 4 months post-pregnancy. So that's the next step we'd like to expand to. So we're going to—
wonderful. Thank you so much.
Yes.
We did have a comment from Jennifer Cianelli with Eskenazi Health to answer our former attendee's question on MERT services within Indianapolis, that Indianapolis does have a mobile integrated response team connected with Eskenazi Health, and there are 7 peer recovery coaches working with multiple community partners. So for those that are interested in an Indianapolis connection, please do connect with Jennifer Cianelli with Eskenazi Health. Great questions. We've got a few minutes left, so please feel free to type in additional questions along the question pane for Mimi Gardner. We'll give a few minutes there. Oh, we do have one question. Mimi, when you look at the overall programming services that you are providing today, it seems to be very adult and or family driven. Are you providing any directed youth services for substance use or opiate use disorder reduction?
At this time, we are not. It is something that we have considered to go in the future, looking at prevention services for community, just to do education, going to schools. We're working with different providers who are social workers in schools, so we are open to doing any presentations because with our peer recovery coaches, one of the beautiful things is that they provide testimony, and so this gives them an opportunity to also talk about when they started using and how they became, not addicted. They became started using drugs, and then what they did to enter recovery. So we are open to doing presentations. But we have looked at grants for doing prevention services. We just have not written any at this time.
Okay, there's a great recommendation from Jamie Steiner with FSSA that identifies that if you have the opportunity to link with Celebrate Recovery, that is a program where they have celebration placed for ages 5 through 13 to assist in prevention, assisting in prevention of child usage.
Okay.
And then for those that are in the Northwest region, Mimi, could you please share your contact information for the program so that folks can access the program information and referrals?
Our phone number is 888-580-1060. And once you get connected, dial 0 and ask for the mobile integrated response team. We also have a email address of Mobile Integrated Response at HealthLink. And if you can see on the end, HealthLink is HealthLinkchC.org, and we can take referrals. If you have any additional questions, feel free to email me directly, or the website, or the web address, or just call and you'll get connected to me.
Sounds great. Thank you so much, Mimi. I think that concludes our questions. Most of the additional comments coming in. Oh, actually, we have one more from Kenesha Smith with Coordinated Care Services. Have you noticed any increase of use and abuse of alcohol? And do you think that many who suffer from alcoholism are not getting the care that they need because many treatment centers are now geared towards opioid use?
We have actually, with COVID-19, seen a big increase in the use of alcohol with the patients that are coming to us now. And we've had patients who have relapsed using alcohol. So the answer to your question is yes. We are getting more referrals, especially during this time frame, with more alcohol use as well as OUD use. And in terms of services, what you're saying, that a lot of treatment facilities are saying, if you're not using that, if you're using alcohol only, we may not be able to help you. So that's why we're trying to make sure that we service those people in addition, with opioid usage and alcohol uses, and we address the alcohol use, because you really have seen an increase since the COVID-19 started. So.
Thank you, Mimi. Appreciate all of your support and the programming and efforts that you're doing today. You've done a great job in supporting the application of evidence-based practice models that you have shared with us today. We appreciate your time greatly. Thank you so much.